Let's discuss about that as we go into the panel. I invite Dr. Radha Ramanan, Dr. Divya and Dr. Mahesh to this panel discussion. Please come and occupy the front seats. So we have Dr. Girija, Dr. Sindhu and Dr. Dinesh Talwar and Dr. Rahul. Dr. Ajay Arora is again an expert in managing endophthalmitis. So we'll straight away go into the panel. The first few minutes of our panel discussion we'll have on the OT asepsis and management, followed by endophthalmitis.
So what Dr. Thomas is going to do, he's going to present some questions and we'll have a panel discussion. If anything comes up in between, we'll have a discussion.
So first few questions are about the ventilation in the operating room and the HEPA filters. How do we ensure the safety of the ventilation and the HEPA filters? Can it go bad at any point of time? And how do we validate these?
If the filters are not functioning properly, then the contaminated air, that is the contamination occurs within the OT from the surgeon as well as the patient. If it is not filtered properly, if the filters are not functioning, then there can be contamination. But in order to prevent this only, we have two pre-filters and a HEPA filter there. It is filtering as well as purifying the air, and also the neighboring air, that is from the outside the OT as well as from other areas of the OT other than the central surgical zone, is prevented from entering the operating zone by the laminar airflow. So all these mechanisms will prevent the contamination in the operating zone.
How frequently do you have to check your filters and validate it?
Actually, a preventive maintenance is recommended every month. That is, every 30 days you can check the filters. But validation is done every 6 months according to the ISO standards. And you have to check all the parameters like the air particulate count, the air circulation changes, because NABH has set certain guidelines for maintaining the OT ventilation. That is, there should be at least 20 air changes per hour with 4 fresh air changes. Then a minimum positive pressure ventilation of at least 2.5 pascals. That is, in our OT it is maintained at 10 pascals, so that the neighboring air does not, contaminated air does not get into the OT. Then there should be filtration, proper filtration of the air with the pre-filters and the HEPA filter down to 99.97% efficiency, so that the air does not contain, that is the, at the grill level, it should be the class 1000. That is, 1 cubic foot of air should not contain no more than 1000 particles of 5 microns or larger. So that is how it is maintained. So all these parameters, the temperature, the humidity, the air circulation, the HEPA filter validation, everything should be done every 6 months.
Thank you, Dr. Girija.
Can I ask one question here for both of you and Dr. Shashikumar? With the COVID having been here, have some things changed as far as the filtration cycle goes? Because there was a lot of talk about having another line set up in the operation theatre, which is an exhaust line. Not only the positive pressure ventilation, but setting up an exhaust line so that whatever the patient exhales, that also gets evacuated. Some of the hospitals in the country, and a lot of money was spent on making these systems. Do you think that is relevant?
As you said, there was a discussion on maintaining negative pressure in some of the areas, but I think we have overreacted in some of the COVID situations. I don't think any case has been reported because of this lack of negative pressure in the IOT. Maybe in cardiac surgery or neurosurgery it would have relevance. But I don't think there has been a reported case of complications that has occurred because of lack of negative pressure. I think positive pressure itself is good enough.
Another thing which I want to ask you, the protocols which madam you said is in a larger hospital. Many people who are sitting here who have smaller practices, do you think the protocols have to be as rigorous, or we can have protocols which are applicable whether it's a larger hospital or a practice? The protocols need to be very rigorous and applied irrespective of the practices.
The protocols have to be the same, whether it is a small hospital or a bigger hospital. I feel that it should be as rigorous as.
Dr. Radharamanan, how will you clean the instruments? How does an ultrasonic cleaner work, and how does it work, if at all?
Ultrasonic cleaner is a good idea, but what about the thing, what is more important is your staff. See, you will have so many protocols in washing. So you yourself in random should observe it, how they clean it. And like Shashi told, it is so important to clean it immediately. Later if you use ultrasound and cleaning it, there is no need of ultrasound even if you are cleaning it immediately. So that trend. So there is sometimes when we have an ultrasound, we think that everything is solved with that ultrasound. So don't take it into that thing, and definitely you should have in its system. So even we can have an OT without a HEPA, but what you have to make sure that your system works properly. So the surveillance, you have to monitor, you have to do everything with evidence. So you have to culture it, you have to do it everything. So that is more important.
That means, yes. Shashikumar, please.
Sir, as I said before, the earliest cleaning, it will not, the biofilm will not even accumulate. There you will have to use the enzymatic cleaning also. Otherwise, pure ultrasonic cleaning alone may not dislodge that biofilm.
So the protocol, that means you have to change the protocol if you find that you can't immediately do the cleaning. Then you have enzymatic cleaning along with ultrasonic cleaning, and then you go ahead to the sterile.
Yeah.
Is that right?
Only thing is that you will have to validate that.
No, so that's what I'm asking. What is validated? Is there a validation done of enzymatic cleaning with ultrasonic cleaning versus immediate cleaning without an ultrasonic cleaning?
I am not aware of a validation this thing for ultrasonic cleaning, but maybe you can do a culture. You can take that effluent, I mean the fluid from that cannula, and then you can do a culture and you can validate it for your OT setup.
So the take-home message is clean the instrument as soon as the surgery is over, as far as possible. If at all it's not possible, go for an enzymatic cleaning followed by an ultrasonic cleaning, and it's not as foolproof as immediate cleaning. Okay. How do we prevent wet packs after sterilization? Shashikumar.
No, wet packs occur because of lack of vacuum cycle in the autoclave. There we will have to check it with the bovidic test or even the helix test. So frequently you will have to check it. They say that once at the start of the cycle in every morning you should do the bovidic test. And if the bovidic test is proper, then you can assume that the vacuum cycle is good. The best thing is you have to go for even the ordinary autoclave. You can attach a vacuum pump. That costs another 60,000-80,000 rupees extra. And otherwise you'll have to go for a B-class autoclave.
How about a comparison between a horizontal sterilizers and a flash sterilizer?
No, flash sterilizer is not a replacement for a horizontal sterilizer. Flash sterilizer is only for sterilizing dropped instruments or in between cases. It cannot replace the conventional horizontal autoclave.
Sir, I had a question for you. You said these bottles, you put the needle on the top. It's also important to tell people that before you put the needle on top, make sure the bottle is cleaned on the top. Because the bottles are transported by various means. They may not always be plastic packed. if they are coming like that and they have collected whatever dust or whatever it may be, they should be cleaned before they put needle on the top. That's very, very important.
The other option is that you will get long spinal needles. That if you put it from the bottom, the needle tip will reach above the fluid level. But the best thing is you keep the airway at the top and discard the last part of the fluid.
Spinal needle, if I think, is about 32 millimeters long. So I don't think 32 millimeters you have to get.
Those are not spinal needles. Those are needles meant for pushing air
Which
above.
we used
But
to
it's
have-
not. Yeah, we used to have
we
it
used to
for
have
fluid air
before.
exchange.
Yeah.
But it's not. But that requires a glass needle, a glass syringe, bottle, not for the plastic
Yeah,
syringe.
those were long needles you get.
In a plastic bottle, if you make any additional hole, it's not going to self-seal. Only rubber self-seals. So what you're saying, Dr. Sai is saying, you have to do it on the top. You can't put it at the bottom. It'll keep on leaking through the edge of the needle otherwise. Your whole OT will get spoiled.
Some of the glass bottles, the plastic bottles come with the rubber stopper in the.
Yeah, so that's a separate thing.
Thank you. I think we'll have to move on to endophthalmitis. Person who had an uncomplicated cataract surgery on the first post-operative day presents like this. Dr. Mahesh, how would you go?
So I will ask the cataract surgeon how traumatic that cataract surgery was. Sometimes they might have put hook and all the pseudo exfoliation if it was a difficult cataract surgery. So I will just but any hypopyon like this, I will take it as endophthalmitis unless otherwise proved. That is the dictum. So if it is a very traumatic cataract, post-traumatic cataract or something like that, I may give a chance with intravitreal injection. Otherwise, I will treat aggressively, right?
I think you have to tell how much were the cells,
Yeah.
how much is the fundus glow.
Or the hypopyon is, fundus glow is also important.
And presence of pain is an important factor, as far as I am concerned. If you have pain, always err on the side of endophthalmitis.
This one looks little inflamed, actually.
Check whether this was pain or whether it's a foreign body sensation.
Yes, that is
Patients have a tendency to magnify if they are not happy with whatever they're getting, no? So even the foreign body sensation from a corneal wound, somebody may take it as severe pain. So you have to first differentiate that. Is that a foreign body sensation you're getting or is it pain in the eye per se?
Right. So if your fundus is visible and it was a traumatic case, probably I may wait for few hours. Otherwise, treat aggressively. So that is.
I presume there is no difference of opinion.
No, I think it's pain, chemosis, lid edema, hypopyon, fundus reflex.
Yes.
That's all. These are the important things. And I think when Dr. Sindhu said, one thing important, ma'am, for the TAS is limbal to limbal edema. In cases of TAS, you will have limbal to limbal edema, while in ENDOPH, there may be a more localized edema. That is again one of the differentiating.
And vitreous involvement, very
And
important.
absence of vitreous involvement in TAS versus that you covered.
Okay, this patient came after 1 month following surgery with 636 vision, no pain, and this is what we see in the fundus. Dr. Divya, how would you go about it?
This may not be a post-cataract surgery related infection. This could be some endogenous likely because, this may not be post-cataract surgery related end of infection. We need to investigate for if any other systemic like diabetes or any other immunosuppressant patient.
If the patient is diabetic, would you still take it as a post-operative, delayed post-operative endophthalmitis or an endogenous endophthalmitis?
I mean the patient did not have any anterior segment involvement much, I think,
Yeah.
because the view is pretty clear. So I don't expect a post-operative cataract surgery presenting a month later with almost relatively clear anterior segment and just a posterior segment involvement like this related to a cataract surgery.
The history of any IV use in this patient after the cataract surgery or during that? This is actually a endogenous endophthalmitis, and this is an ambulatory endogenous endophthalmitis. In fact, it's very important to keep in mind there are two types of endogenous endophthalmitis. One scenario is patients who present in the ICU, and these patients are very sick and all those issues about clearances and all come in. And those patients fungal endophthalmitis a more common cause. The second group of patients is ambulatory patients. And we see them a lot more in this country than you see them anywhere else because of this tendency to give glucose chada do, theek ho jayega. So what happens is patients go with and the general history is a history of fever or some diarrhea, and the patient's been given an IV glucose at that time. And the patient comes 15 days later and he has an endophthalmitis. So this is likely to happen. This is an ambulatory patient likely to be an endogenous endophthalmitis due to some source which was given to him through some IV or some other form of...
Okay, we'll skip this. One patient had the first intravitreal injection for a postoperative endophthalmitis. There is absolutely no response. It's status quo. It's not improving. It's not worsening either. So what next after 24 hours or 48 hours? Would you go for a repeat injection or would you go for a vitrectomy? Dr. Mahesh?
Immediate vitrectomy. No question. Because if the dramatic improvement is there with intravitreal injection and the view is better, vision has improved, fine. But no effect, there is no point in waiting. Exactly everyone told, no? Now it has become, vitrectomy has become such a we can do it.
And so, how often do you explant the IOL in an endophthalmitis?
Not at the initial vitrectomy. Not at the initial vitrectomy. Because it has got medical legal implications also, if I am not wrong. Suppose one patient comes with endophthalmitis, initially itself you remove the IOL, it indirectly blames the cataract surgeon and it will go for a problem. So not at the immediate thing, but the recalcitrant cases, acne, fungal, all these cases we may have to. So case by case you have to think about explantation of the IOL.
And Talwar sir, from your talk, you talked about the newer antibiotics, meropenem and tazobactam. Would you consider those as first-line drugs in any case?
The moment if you get the endophthalmitis within 48 hours,
yes,
and specifically if it's within 24 hours. If it's within 24 hours, I won't even use my mind. I will definitely start with tazobactam along with vancomycin. It has to be gram-negative.
Exactly. We are also following the same thing. Violent, immediately, tazobactam, piperacillin. So that's...
So Dr. Dinesh, you mentioned something which was in a talk, I don't know whether I understood it right, that if you're doing a vitrectomy and you're doing the complete vitrectomy, antibiotics are not required.
See, basically two aspects. One is if you're doing a normal vitrectomy, a conventional vitrectomy, and that means obviously there was a PVD there and you managed to clear everything up to the equator. You've done a core vitrectomy. Actually, when the reason I would avoid an intravitreal is because now, you know, there's a controversy regarding what dose to use. Payman used to advocate decreasing the dose to 1/10. Now 1/10 I believe actually has no role, and we did a study where we actually compared this. It was actually a 4-arm study, one arm with vitrectomy, immediate vitrectomy, one with delayed, and in both, one with TAP, one with intravitreal antibiotic, one without intravitreal antibiotic. And we found that there was no difference in the outcomes when we did not give the antibiotic. So after that I stopped adding intravitreal antibiotic even to my conventional vitrectomies. But in silicone oil related vitrectomies, anyway I can't put in an intravitreal. You see, if I put the intravitreal and then I do a fluid exchange, fluid air exchange and put silicone oil, there is no antibiotic left. So I'm just wasting my time putting an intravitreal. And secondly, you don't need that intravitreal because with silicone oil, the systemic antibiotics now give you a very high level of antibiotic within the eye.
Before we conclude, one last question. If there is no PL or PL is doubtful in an established postoperative endophthalmitis, would you go aggressively or would you go for palliative measures? Dr. Divya.
Palliative depends upon, like in case if you feel that there is a slightly chance for a visual improvement, and if you can do a vitrectomy through the hazy cornea with the PL vision, maybe that the corneal edema or the infiltrates might be there on the cornea, then depending upon your visualization, you can plan for vitrectomy. If some prognosis is there, definitely would go for a vitrectomy.
No, would you go for a radical vitrectomy with silicone oil?
If possible, if the view permits. Yeah, because it's such severe in end off, many a times you would see that the corneal involvement would be so severe that we may not permit you to go inside for a good radical vitrectomy.
So thank you very much, all speakers.
One
and
last
panelists.
comment by, with Dr. Rahul's thing. I think what you said, I wanted to do because I've used it. I told my patient that he had recurrent this thing, and I said, I'm going to use a Brahmastra for you. And this was a Brahmastra. It worked wonders. It does work. 0.025%. I didn't give an injection, but irrigating fluid, and the patient is happy. It's not recurred after that.
So are you advocating it as the new?
I'm not saying it's a new thing I'm advocating. I'm saying this is like if everything else is repeatedly failing.
But why shouldn't I not do it in every case then? If it's safe and it works wonders, why should I wait to first spoil the eye and then go and put it?
So I have put a food
I
I have
think
put
it's
a
time
food
for
for
the next
thought
session.
for you,
We'll have
Dr.
to leave the
Dinesh,
scene.
so that you can.
Thank you.